Okay. Okay. All right. Thank you so much, Faith. Welcome, everybody. I am Rhonda Vargas. I'm the program manager for the Rural Healthcare Provider Transition Project. Thank you so much for joining us today as we talk about the topic of hospital at home for rural communities. And so by attending the webinar, participants are going to be able to identify healthcare concerns that may be solved by implementing a hospital at home model of care in your organization. Looks like can you
I'm just
mute
on this webinar.
Thank you. The second is recognize the barriers in launching a hospital at home program and the limitations of acute care in the home, and then also reflect on the lessons learned from a rural hospital at home project. So we have two speakers with us today. Dr. Margaret Paulson is an assistant professor of medicine at the Mayo Clinic College of Medicine and Science. She has experience in patient care across the spectrum of internal medicine. She currently practices as a rural hospitalist in the Mayo Clinic Health System in the Northwest Wisconsin region, and that's NWWI, and leads the home health team in NWWI. And she's in the clinic's advanced care at home program, which is an innovative program offering hospital level of care in the home. The launch of this program allowed Dr. Paulson to call upon her experience in outpatient and inpatient internal medicine to expand high-quality telemedicine in transformational ways for the Mayo Clinic. Through that ACH, she has been involved in numerous healthcare delivery innovations, focusing on sustainability in the rural home hospital, particularly through leveraging technology and AI for improved patient experience and efficient care delivery. Maren Norenberg is an operations administrator at Mayo Clinic Health System, supporting advanced care at home, community pediatric and adolescent medicine, integrated behavioral health, rheumatology, and research and innovation in Northwest Wisconsin. Maren holds a Bachelor of Science in Psychology and a Master's in Healthcare Administration. She has held multiple leadership positions spanning clinical, surgical services, and hospital operations in both academic and community-based medicine settings. Maren is passionate about healthcare innovation and leveraging technology and science to improve patient care. We are so honored to have both of you with us for this next hour. Thank you for joining us, and I am going to turn that over to you.
Yeah, thank you so much, Rhonda. And on behalf of Maren and the Mayo Clinic Health System, just really appreciate this amazing opportunity from the National Rural Health Resource Center to chat with you all about a topic that I'm super passionate about, which is hospital at home, and in particular, the rural hospital at home. So just want to thank you. Next slide. So as far as disclosures today, Maren and myself have nothing to disclose, but I do think it's important to know that Mayo Clinic has an investment in Medically Home, which is a hospital at home partner. So just wanted to let you know about that. Next slide. So just a few learning objectives today. The first is to identify healthcare concerns that may be solved by implementing a hospital at home model of care in your organization. You know, a lot of people see hospital at home as the shiny new toy, and before jumping into it, we really want to think about the why behind hospital at home. The second objective is to really recognize some of the barriers that are there when you do decide to launch a hospital at home program, as well as the limitations of acute care in the home. And then the third is we're going to just take some time to reflect on lessons learned from our experience launching and maintaining a rural hospital at home program. Next slide. Okay, perfect. Great. So, and just to back up too, I it was fun for me to see there's some people from North Dakota. I'm a North Dakotan. Grew up in a very tiny town, so rural medicine has always been a part of who I am. And it's been just so exciting to blend that with a new iteration on healthcare, hospital at home, and leveraging technology to help people in our rural communities. So again, thanks for this opportunity. And certainly when I start talking about hospital at home, people often say, well, isn't that like going back in time, right? And some of you may know this very famous painting, The Doctor by Sir Lucas Fields. You know, healers have been going to the bedsides of patients for millennia. So this is not new, right? Like we have been doing this for a long time. Next slide. But it wasn't until 1751 here in the US. So Dr. Thomas Bond, he was a physician who grew up in Maryland and did his training over in London and Paris. And he was there training in the hospitals, and he was just amazed at how you could just go from bed to bed to bed, not room to room to room, because they didn't have rooms. They probably didn't even have sheets. It was just like people lined up in a big ward. But he was astounded, like that was amazing to him that you could be so efficient with the care you provided. So he came back, came in, talked to his friend, Ben Franklin. And so in Philadelphia, there were just people all over the street, sick, downtrodden. And Dr. Bond was like, hey, Ben, we need to do something about this. Let's create the first hospital. So that's what they did. And their mission was really to care for the sick, poor, and insane who were wandering the streets of Philadelphia. So next slide. So fast forward now, over 270 years later, we went from 0 hospitals to over 6,000, over almost 1 million hospital beds, 36 million admissions annually, at an astounding cost of over $1 trillion, right? This has been unsustainable, the way that healthcare costs are rising. Next slide. So when people ask me, like, why would we go back in time? Why should we return to the hospital at home? I you know, being a bedside clinician, I could give you a million reasons, right? And it's really the voice of the patient that's most astounding. So, you know, COVID highlighted this quite a bit too. I can't see my family. The food is terrible. And maybe your institutions have amazing food. I love Mayo Clinic. We are a fabulous institution, not known for our food. Patients sometimes are happy, but often would rather have home cooking. How many times have you heard this? Like, I'm stuck here. Why? When am I going to get out of here? Nobody tells me what's going on. And people often complain about the quality of sleep that they get, right? The beds are uncomfortable. There's all kinds of noises and dinging and delirious patients maybe in the room next door. Next slide. So it really hit home though, when some of my colleagues on the Arizona campus back in 2020 had published this piece in Annals of Internal Medicine. They took the CIA interrogation manual and they compared it to what happens here in the hospital. And this is despite our best efforts, right? But we strip people down, we give them a uniform, we often flip their days and nights, we pepper them with questions, oftentimes not even letting them finish. And people wonder, like, why don't you like being in the hospital, right? Because it's not a great experience, despite our best efforts. Next slide. So I guess I just want to encourage you all to think about your why. I mean, you're all here for a reason to learn about the hospital at home model, especially in the rural communities. But what problems can hospital at home solve? Next slide. So first is capacity. And this was really highlighted by COVID, right? We ran out of beds. And I think a lot of institutions now are experiencing this post-COVID capacity issue as well. Certainly we are. We had capacity issues even before COVID. But it's difficult, right? It takes a long time and a lot of money to build a new bed tower. You know, beds are costing $1 to $2 million in, maybe the Midwest. On the coast, it can be $5 million to earthquake-proof a room. So it's very expensive and it takes a long time. These were just a few headlines from COVID. Certainly Wisconsin, Minnesota, just like you all, were probably hit very hard. This picture of the paramedic is one of our community paramedics, actually, Adam Glass. The Washington Post came out and visited us here in Eau Claire during the height of COVID, and that was a hard time. They actually followed one of our patients home, so that was pretty exciting. But yeah, capacity is tough, right? Next slide. The next why to consider is quality, right? So despite our best efforts, people come into the hospital, they may get infections that they didn't come in with. They may get delirious. They may end up returning to the hospital for readmissions. So there's enough data now for 2 meta-analyses. The US has been kind of a late adopter of hospital at home. Europe and Australia have been doing this for decades now. So a couple of meta-analyses show that, people actually die less frequently. Readmissions are lower, cost is less, and certainly patient satisfaction is much higher. People really enjoy being at home. Next slide. So just some more about quality. So a couple of my colleagues, Dr. Jared Conley, he's an ER doc out at Mass Gen Brigham, and David Levine, also at Mass Gen Brigham. So the bottom study there has, to this date, it's the biggest RCT, 96 patients, where half went to the brick and mortar, half went to hospital at home. And what they found was great, right? So when people go to home for hospitalization, fewer resources were utilized, right? If I'm taking care of a pneumonia patient in the brick and mortar hospital, it's really easy for me to just order a whole bunch of things without even thinking about it. But when people are in the hospital at home, clinicians have to sit and ponder, okay, is this test I'm going to order really needed, or is it just making me feel kind of better about, having that information available? Because in the hospital at home, you have to coordinate everybody going there. So people think twice about what they're ordering. People were more active at home, length of stay, quality, that all seemed to be better or equivalent. For Levine's study readmissions, they didn't have any escalations back to the brick and mortar, which was great. And the big thing that he found was cost, 38% less cost, which was great. The top study, Dr. Conley, a lot of kind of no-brainers. People slept better at home. They were moving around more. They recovered better. They didn't fall as much. They had more engagement in their care. And certainly they weren't getting as delirious, right? They're in an environment that they're familiar with. So restraints weren't needed as often. Next slide. So the next thing to think about is utilization. If you have a utilization problem, hospital at home might be a solution for you. So this study was Dr. Descherie out at Mount Sinai in New York. So they've had a hospital at home program for a while now. They did a demonstration program with CMMI, where they did a 30-day bundle. So their acute hospitalization with services up to 30 days. And what they found was pretty amazing, right? So readmissions were cut in half. So were ED visits within the 30 days. And this was pretty astounding. Skilled nursing facility admissions, 10% versus 1.7%. So if utilization is a big problem, hospital home might be a solution for you. Next slide. And in fact, the people at Mount Sinai were so excited about these results that they took out a one-page ad in the New York Times saying, if our beds are filled, it means we failed, which is just, audacious, right? Granted, this was pre-COVID and now everyone's beds are filled and maybe that means something different. But yeah, they were so happy with the results that they wanted to tell everybody about their hospital at home program. Next slide. I'll hand it over to Marin.
Thank you, Dr. Paulson. So a key component to our healthcare strategic approach is the virtual hospital at home model, which seamlessly combines in-home resources, cutting-edge technology, and virtual clinical expertise. This innovative model allows us to extend care beyond the walls of the traditional hospital settings, benefiting patients who live 30 to 35 miles from our physical hospital facilities, but connect them with clinical expertise thousands of miles away. Next slide, please. At the heart of our program lies our medical command center, manned by a dedicated team of APPs, nurses, and command center physicians. It operates 24/7, 365, ensuring that patients receive continuous monitoring and support throughout their hospital stay. The highly skilled team is also seamlessly connected to clinicians that are then dispatched to the patient's home, forming a unified care approach. Our success in achieving this level of integrated care is made possible by harnessing the power of technology. By leveraging advanced tools and systems, we establish a close collaboration with internal and external partners across the United States to deliver exceptional care in communities that might be thousands of miles apart. One of the most significant advantages to our approach is the ability to break down historical barriers that previously hindered access to critical resources in local communities. Now patients in even the most remote areas, thousands of miles apart, can benefit from expertise and resources available at our command center, ensuring a consistent and high standard of care for all. Next slide, please. Central to the care model is the integration of technology within the patient's home, ensuring 24/7 connectivity to the care team. As part of this initiative, each patient receives a personalized tablet upon admission. Through the tablet, patients can receive inbound and make outbound video calls with their care team, fostering real-time connections. The device also acts as a centralized hub, displaying patient schedule and daily appointments, as well as providing essential patient education materials to facilitate informed decision-making. The tablet is designed to sync effortlessly with various Bluetooth-enabled biometric devices, which you'll see pictured here, including automatic blood pressure cuffs, pulse ox, and scales, allowing the care team to access the patient's vital signs remotely and monitor health status and progress. In addition to the tablet, patients are equipped with telephones, text apps, and internet boosters that are pictured here on the left to guarantee a stable and reliable connection and redundancy, as we prioritize the safety and security of patients, also by incorporating the life call systems. Next slide, please. Our supplier network replicates these hospital services such as imaging, phlebotomy, meals, courier delivery, etc. And we leverage both internal and external vendors. Partnering with the internal suppliers helps fill resources gaps and bring specialized expertise, enhancing the care that we provide to our patients. This collaborative approach ensures patients receive top quality services within the comfort of their own homes. Next slide, please. The technology platform. The next component is our technology platform that complements our EMR system. It efficiently processes locally collected data and then transfers it into our EMR system, streamlining the flow of information. This integration ensures a smoother and more efficient experience for providers, promoting accurate and timely patient care by allowing data and orders to flow in and out, and thus minimizing the number of programs utilized by providers and reducing the room for human error. Furthermore, the platform serves as a central hub for scheduling orders, including those visits, labs, therapies. By consolidating these functions, we simplify the care coordination process, enabling a more organized and coordinated approach to patient care. Next slide, please. The patient journey has multiple pathways, but operating under the CMS waiver, our hospital at home program follows specific pathways for patient admissions. There are three primary routes which patients can be admitted to our program. The first pathway is through hospital substitution, which is via the emergency room. Patients would be assessed and evaluated in the emergency department, but then rather than being transferred to a traditional bed within the hospital, they would be immediately sent home upon admission. The second pathway is known as reduced length of stay, involves patients that are initially admitted to the hospital for clinical reasons, such as they need a procedure or to increase their clinical stability. Once clinically appropriate, then those patients are transferred home to complete the remainder of their stay. And then finally, another pathway is clinically appropriate patients can go directly home from the PACU. We've seen patients sometimes go to the ED to PACU or OR to PACU to home. So whatever the pathway, though, the patient's care and length of stay mirrors what you would experience in a traditional brick and mortar hospital setting. Next slide, please. Since go live, we provided care for over 815 patients, totaling over 3,000 brick and mortar bed days saved. Our commitment to delivering top-notch care is reflected in our patient satisfaction scores. Over 91% of our patients have expressed their satisfaction with our program, stating they would recommend it to friends and family members. Not only do our patients appreciate the program, but our providers who work with our hospital hope program do as well. We've done provider surveys that show 4.5 out of 5 of them, the likeliness that they would also recommend the program to one of their loved ones. This feedback serves as a testament to the exceptional quality and effectiveness of our services. Next slide, please. So it's important to acknowledge that many barriers do exist, though, to launching a hospital at home program. Starting a new program takes significant time and resources, which may be in competition with other institutional priorities. Resources in rural areas can be scarce, so securing the necessary personnel, technology, infrastructure will require significant support from key stakeholders and interdisciplinary collaboration. EHR integration is dependent upon capabilities as well as securing IT buy-in and resources. Regulatory environment varies by region, which can make it challenging to navigate. There are reimbursement challenges depending on the insurer, as not all payers reimburse for this model of care, which necessitates advocacy efforts. Telehealth access, as we all know, is more challenging in rural communities due to connectivity. And finally, changing local culture is imperative to any successful program. Anticipate skepticism for patients and providers. So concerted effort will need to be put in place to build trust, educate, and eventually gain buy-in. Next slide, please.
Yeah, so when we talk about limitations to the program, we have to highlight the fact that this is, essentially leaving people out from the beginning, right? Hospital at home implies you have a home, right? So there are people vulnerable and marginalized who may not have access to this. Certainly, if your home is not a safe place, that is not somewhere where we want you to spend additional time, especially if you're sick. This program can be challenging for English language learners. We do our best to try to make the platform accessible for people who speak all languages, but we're working on that. It is challenging if somebody doesn't speak English. Disabilities, probably more intellectual disabilities and physical disabilities. People who have physical disabilities probably are already set up. They have their home accessible and ready to go. Essentially, they've been living there. But intellectual disabilities make it harder to interact with the iPad that we bring to the house, and people who are coming to the home who may be strange, and it may not be the best. And certainly rural, right? Like all of the hospital at home iterations before us were really in densely populated urban centers. It's just harder to try to make all of this happen in rural places where there are fewer resources, fewer redundancies, and frankly, facilities who may be just trying to hang on by the skin of the teeth. So it's hard. We get that. Next slide. Another thing, before I get into this too, I realized maybe we didn't do a great job of kind of setting up where we are in the Mayo system. So Maren and I are talking to you from the Eau Claire region of Wisconsin. It's very rural, especially when you get out of Eau Claire proper. And we take care of patients within a 30-mile radius of Eau Claire. So you get out even 10 miles and you're looking at cornfields, right? So we're part of kind of this hub and spoke model. Our command center sits on the Florida campus in Jacksonville. They're coordinating care for their Jacksonville population, but also for our local population and across the campus in Phoenix, Arizona, as well as some patients in Rochester. So it is, I think, a unique situation where we have a command center coordinating care across multiple sites, 3 different time zones. But just to kind of put that into mind. So a little bit more about the rural hospital at home itself, because I think that's important to think about. Yes, we're part of the Mayo Clinic, but our region is a 5-hospital region with the hub and spoke model, the hub being Eau Claire, and we're surrounded by 4 critical access hospitals. I'm sitting at one of them today, so all 25 beds or less. What is challenging, I think, is trying to get resources, right? So when we were setting up our program here in Eau Claire, we were doing it alongside of our colleagues in Jacksonville, but we needed to evaluate our existing resources. What did we have that we could bring to the table? One of the things we did bring to the table was our home health agency. So that was an amazing resource. If you can leverage that out in your rural communities, that's a great thing to bring to the table. Another thing to think about is what can be done virtually, right? So patient populations are different. At our sites in our hospital at home program, they're vastly different. We do a lot of bread and butter medicine, heart failure, pneumonias. We took care of a ton of COVID patients, but our colleagues on the Florida and Arizona campuses, they take care of a ton of patients with transplants and cancer. And so we need to think differently about, okay, what can we do virtually? What has to be done in person, and leverage what you can do virtually. And that leads into the next piece about just anticipating the needs of your patient population. So those transplant patients have different needs than our bread and butter heart failure patients up here in Wisconsin. And really, it's been fun to watch the chat. It seems outlandish, I think, for a lot of systems, because I've talked to a ton of people and they're like, well, yeah, you're a Mayo Clinic. Of course you can make this happen. Well, when I first started out, I was at my critical access hospital, partnering certainly with Eau Claire, but partnerships across our Mayo enterprise was really the key to bringing hospital at home to rural Northwest Wisconsin. And that's partnerships at many different levels in the community. So home health agencies, mobile integrated health, those are community paramedic programs, perhaps, that might be already existing in your communities. Partnerships with providers. So we've had some subspecialists, some of our departments really jump on board and support us. Our ED has been a huge supporter of this program. Like, we've been working with them to make it easier to get patients from the ER to home than to have to admit somebody to the brick and mortar hospital, because a lot of times those patients are boarding or wait times are just really long for beds anyway. So we're trying to make friends with our ER by making their lives easier, but also understanding what do your specialists or what do your providers in your system need, what's on their wish list. And the other piece is partnership through technology. So certainly hospital home is something that you don't necessarily need to have a tech platform for. A lot of systems were doing hospital at home without the added comfort layer of technology before it really, virtual care really took off. I think for us, it's nice to have a way for patients to connect and see somebody in the command center, instantaneously, to be able to have that, the vital signs flow into the tech platform and into our EHR Epic. That's really been nice. But, that has only been, this technology partnership through Medically Home was very strategic. Next slide. not everything has been roses though, right? Like it has been a struggle at one point or another for a whole bunch of different things. So certainly we've learned a ton. Connectivity is a huge thing for a lot of patients. We have patients who essentially live off the grid. They don't have cell phone access. They don't have wireless. So we need to make sure that we offer the program to patients where we know it's going to be safe, where we can respond in a timely manner, especially with adequate connectivity. The next lesson is about, I think this is pretty standard for a lot of rural programs, like even outside of hospital at home, just one staff absence can kind of derail things, right? So even in our brick and mortar hospitals, if we have a nurse call in, their kiddo gets sick or something, that can really change census, and it can really change things for hospital at home, because if we have somebody out, that affects not just today, but it affects being able to admit patients for the next couple of days sometimes. The next piece about being plug and play, this is hard for rural settings, right? So there's a lot of hospital at home providers out there now, and this idea of just coming in and setting up a program, I think, is much easier in an urban setting where you have a ton of redundancies, right? There are a lot of pharmacies if you can't use your own pharmacy. There are tons of home health agencies, but in our rural setting, we haven't had the luxury of partnerships with outside home health nursing facility or home health nursing agencies or community paramedics. So it's just harder. You have to think more about what you can do with what you have. Bundling of activities becomes really important too. So when you send somebody out 25 miles in the middle of nowhere, you want to make sure that that person is doing A, B, C, and maybe even D and E. So they're drawing blood, they're doing an assessment, they are bringing medical waste back. There's all of these things that you need to think about before they go out to the home. So as much as you can bundle, the better it is for efficiencies. And that kind of gets into this next piece about valuing the generalist. So certainly somebody who operates in a very subspecialty setting may not feel comfortable with the type of care that somebody in a home hospital may get, right? So I know that our internists and family med docs in rural settings wear a lot of hats, and they feel really comfortable practicing across a broad range of family medicine and internal medicine. Well, when I talk to some of my hospitalist colleagues about this, they sometimes get a little cringy, like, oh, well, what if you don't have the ICU right next to you? Or what if you don't have, a CT scanner down the hallway? So feeling comfortable practicing in kind of an environment where there aren't as many resources, I think, is really a valuable skill to have. Technology innovation. So when we started, we were super inefficient. We tried very hard to automate tasks to free up our team members, our clinicians, for patient care. And one of those is AI for patient selection. So when we started, we were using a spreadsheet and trying to track potential patients that way. Well, that was really inefficient, and we had tied up one or two or sometimes even more people just reviewing charts, trying to figure out who would be most appropriate. Well, over time, we've worked with our colleagues across the enterprise to develop a tool within the health record that identifies patients. It can scan essentially the whole hospital within a few seconds and assigns a score to like a fitness score, so we could approach those patients first. So that has freed up team members, which in our rural hospital at home has been essential because we want as much hands-on care provided rather than, having team members do administrative chart reviews. We've worked really hard at trying to decrease drive time and patient wait time. So as efficient as we can be about scheduling patients across the day, we work really hard at that. And I talked a bit about the EHR identifying candidates. We've leveraged all kinds of tools within the EHR, as well as cognitive computing that you may already have existing to. We use a deterioration index in the brick and mortar that we took over to the home hospital as well. Next slide. So how do we move forward though? We know access and equity, especially for our rural patients, isn't there. So regulatory wise, this is a sore subject for me. I live in a state in Wisconsin that doesn't allow Medicaid patients to have access to the program. It's not reimbursed. So that's been a problem because we take care of a lot of patients on Medicaid or even uninsured. The second regulatory piece that I struggle with too is that there's been this amazing CMS waiver back in 2020 that waived the 24-hour nursing requirement and essentially allowed us to get reimbursed the DRGs that you would in the brick and mortar for pneumonia, heart failure, cellulitis, all of those things. But it doesn't apply to critical access hospitals. So when I'm on service at our critical access hospitals and I'm taking care of patients who could be great for their home, I struggle because, this is an equity access issue. And I even had one patient, oh my gosh, I was rounding. He had an infection, osteomyelitis of his toe, needed amputation, and then was going to be on antibiotics, IV antibiotics for several more days. And he actually had read a case report that I helped write and publish. So he Googled me, just as patients do. They Google their care team. And he saw this article. He was a retired university professor. So he read it and he said, well, why can't I go home? So I had to explain to him that the CMS waiver didn't apply to critical access hospitals, which was a big bummer that day, but he did great. And technology, it is a gap, right? We need more connectivity. We need more point of care diagnostics that will create efficiencies, more automation of tasks. One thing I haven't mentioned is medications in the patient's home at baseline can be a bit disastrous. Sometimes people don't know what they have, what they're taking, medicines everywhere. And when we designed our program, we wanted it to really reflect the control that we have in the hospital. So we partnered with a company that has, it's like an in-home dispensing system. So it's a 1 cube with their scheduled medicines that are in there, and then another cube that has all of the most common as needed medications. So that's really cut down a ton on people going back and forth to the home, as well as just patient time. If they get nauseous, they'll push the button, talk to their nurse, and then the medicine comes out of the cube, rather than having to put somebody in a car, drive 30 miles and show up later with some Zofran. So we need more things like that to, especially in the rural environment, make this possible. Those innovations require partnerships, right? So clinical partnerships with, we've seen across with team members from different sites like Florida and Arizona. We've brought the rural flavor to hospital at home, which has been exciting. Industry partnerships. It was interesting for me to be on this journey, and before I was leading the program here. I'm sure like many of you, there was just kind of this black mark on industry, like stay away, don't ever take a drug rep lunch or anything like that. And I'm not saying that's what we should go to, but we need industry partnerships to be able to advance medicine, advance science. I think of my 13-year-old, he had his appendix out a couple months ago with just one tiny incision through his umbilicus. And, 20, 30 years ago, that would have been a big gash in his abdomen. But those surgeons partnering with industry leaders to develop those tools and techniques, that's what it took to be able to get to this point in time where it's just this tiny little incision and amazing recovery. Partnerships through the community too. So how can we partner with people in the community providing meals and social workers and community services? That is really important. The rural hospital at home, I think, brings a whole different flair of social determinants of health. And how do we be intentional about measuring those social determinants of health and vulnerability? And that, I think, requires a lot of research. So we're trying to push some of that research here at Mayo Clinic and share those lessons learned with great folks like you. But certainly we'd love to see the government more involved in research efforts for serving more rural patients. Next slide. So just to kind of wrap up here with our learning objectives, we talked about identifying healthcare concerns that may be solved in your organization by implementing a hospital at home model of care. We talked about some barriers in launching a hospital at home program and some limitations as well. And then we talked about some of the lessons that we've learned from our rural experience in hospital at home. So next slide. So just for you guys, if you want some more information on the hospital at home concept or resources, there are two great groups that I would recommend: the World Hospital at Home Community, as well as the Hospital at Home Users Group. So Users Group is based in North America. They are really active. There's a meeting coming up this fall. It's virtual. Definitely check it out. And World Hospital at Home has been so interesting. I presented there at their conference earlier this spring in Spain, and it was on the rural model. And it was wonderful just how many people from around the world came up and said, oh yeah, we're rural too, and we really want to know how to take care of our rural patients. So so that's a great organization as well. And with that, I will pause. Maren, did you have any other comments, or otherwise we can just open it up for questions?
Oh yeah, it looks like there's several questions in the chat.
Yeah, I can help you with those. So let's start off with this one. Catherine Miller wanted to know if you could talk a little bit about reimbursement, and also wondering if you have worked with Wisconsin Hospital Association to see if they can advocate for Medicaid reimbursement.
Yeah, we would love for the Hospital Association to advocate for Medicaid. We have an advocacy person from Mayo Clinic that we've been working through. So my assumption that he's been working with the Hospital Association, but certainly I can double check on that. The medical director for Medicaid in Wisconsin is new into his role, and so we were just giving him a little bit of time to kind of adjust before really going for the gusto. But yeah, we've been working for this.
And Margaret, can you hear me? This is Catherine.
Yeah.
Yeah, I private messaged you as well because I'd love to talk to you. And with the Office of Rural Health in Wisconsin. So the reason I put that point about talking to the Hospital Association is because we're part of the University of Wisconsin and we certainly cannot lobby. So we love that the Hospital Association is in a position where they can step in and attempt to advocate on various issues So I'm glad to hear you're working with them. And can you tell me which 4 cause it is? It just the Mayo cause, the critical access hospitals are the ones that you work with in Wisconsin?
Yes.
Okay, great, that answers it, but I'll contact you. Does your information, oh, there it is. I'll
Yeah.
contact you and we'll maybe set up a time.
That sounds great. Thank you so much.
Oh, but I will ask, does Medicare cover this though? If
Yes.
I know Medicaid doesn't, so.
Yep. So this was part of the CMS waiver back in 2020.
Wonderful.
Yep. So CMS, it's just, you get the DRG just like you normally would in the brick and mortar. Your program has to be certified though and go through CMS. So there's an application and process and reporting structure.
And they're not getting rid of that waiver like they are so many others?
It was extended in the December omnibus bill through 2024. So there is a Advanced Care at Home coalition of healthcare systems who are working together to lobby for permanent reimbursement.
Great, awesome, thank you.
Of course.
Thank you, Catherine. And next question is, what are some of the most common diagnoses for patients?
Yeah, I can tackle that again. So for us in Wisconsin, it is cellulitis, heart failure, pneumonia, bacteremia, UTI, acute kidney injury. So these are the sick but stable patients that you would see in the hospital. Maybe, we partner with our surgical partners. Maybe they have a procedure done and they're just waiting for cultures for the next few days. We'll take those patients home too. But yeah, for us, it's bread and butter medicine.
And another question is, what EMR do you utilize?
We're using Epic.
And another question is, how does a rural facility implement or manage such a program with these kinds of infrastructure and staffing requirements without the benefit of a Mayo type system helping to foot the bill?
Maren, do you want to take a crack at that first?
Yeah, I'll certainly try. Yeah, I mean, it's still something that we're working on today, and certainly being mindful of what sort of resources. It's an interesting dynamic in terms of there's limited resources in the rural communities. So sometimes you have to leverage partners, but you also want to be mindful of then what the financial impact is. So, I mean, our goal is to be less than it costs to be in bricks and mortar. And so we're leveraging, again, looking at who do we have in our communities that we can work with, what resources do we have internally that we can work with, as well as then what does the cost look like. So as I said, this is ever evolving. I'm not sure that we have, the final answer today, but it's certainly always top of mind. Dr. Paulson, do you have other comments on that, having been here from the beginning?
Yeah, no, I think you nailed it. It is hard because we've had to leverage partnering with the ER and floating staff. If our staff aren't busy with us, we float them to support the brick and mortar. So I think there's ways to do it. You just have to get creative.
Any other questions? All right, hearing none, I will turn things back over to Ron, and she will close us out this afternoon.
Right. Thank you so much. And Maren and Dr. Paulson, I just want to say really so sincerely, thank you so much for being our presenters today. We really appreciate it. And we appreciate the pioneering that you all are doing to bring the hospital at home into rural, because as you said, it's a lot easier to do in urban. So thank you for this pioneering work that you are doing. So while we are wrapping up, you will see that Faith will be putting up the pre-webinar questions again so that we can capture knowledge gained, and then she'll put a couple other satisfaction questions up. If you guys, so just as a reminder that today's recording and the slides are going to be on in 5 business days will be on our website for rural healthcare provider transition project. And Angie, if you can put some of those links in the chat box, if you haven't already, that would be wonderful. Also, Faith is going to be putting the link in for the ACHE credits. If you are interested in getting one ACHE credit, please do click on the link, answer the questions, and you will be receiving a certificate for those. She will also be sending out that link later in an email to everybody as well. So Faith, do you have 2 more questions to put up before I just go ahead and close?
Yes, I do.
Okay, if you go ahead and put those up. And also, it may be that Angie's already put in the link for our newsletter if you wanted to be on the monthly newsletter for RHPT. Also, we encourage you to take a look at the website. We are currently taking applications for our next cohort of hospitals and clinics to receive a very focused technical assistance that will help move hospitals and clinics to prepare for value-based care. All right. Faith, if you'll do that last one, please. Thank you so much. And we appreciate everybody who took a moment to answer our polling questions. It's very helpful for us to learn and to continue to get better and better and better. But again, Dr. Paulson and Maren, thank you so much for being with us today. We appreciate your work and your presentation and the time and energy you put into this. And thank you, everybody who participated today. And please reach out to us if there's anything at all that we can do. Otherwise, I hope everybody has a nice rest of your day.